Welcome to HIMSS Europe 2019 and welcome to our HIMSS TV broadcast. I'm your host, Nicole Couture, and I'm thrilled you could join us. First up, we're excited to welcome Stephanie, who is the founder and director of The Big C. Stephanie, thank you for joining us.
Thank you for having me.
Our pleasure, our pleasure. Can we kick off by having you tell us a little bit about The Big C?
Yes, I will. Well, The Big C is my little baby. When I was diagnosed with cancer at the age of 26, I really needed a positive place because during my treatment, it was very hard. I lost my identity. I lost a bit of hope of the future. And I needed a place where I could find myself again and where I could find people like me. And there wasn't a place like that. So I decided to just open my coffee corner, call it The Big C, from the big cancer or community or coffee or care, and make sure that I created a platform where people could get together and find their resilience. At this moment, we have 2 coffee corners like that. We also have our own coffee brand because from the profit, we invested in post-cancer care for young people. So that's The Big C, coffee, cancer, and care.
That's amazing. What a great idea. And what are some of the initiatives that you guys support for patients who've just come out of treatment?
First of all, we organize peer-to-peer contact. I think that's the most important thing, to find peers. And in my situation, I was 26, so I couldn't find peers from my age. And that was very hard because I really felt that I was punished being a young patient. So we make sure that there's a low threshold and there's just nice coffee moments, or sometimes cocktail moments, to be honest, because alcohol helps. So we organize contact. We do a lot of activities, but then we also organize a lot of skill building. We transform them to patient advocates. We give them leadership trainings or public speaking trainings, and then we also do some policy work. So you can say that at the beginning we just try to connect the community, but then we try to make them very good stakeholders in the bigger healthcare debate, like we have here.
Right. And, you know, there's some of the things that you're going to talk about this week is sort of that wider community and how important that can be when a patient is going through care. Talk to me a little bit about that role of the wider sort of, call it, care team that could be made up of people in someone's family, but also their wider community.
Yeah. And up until now, it's really missing because I'm a patient advocate for 5 years now. And they always say our innovation is driven by patients. Patients are put at the heart, at the center of what we do. But when you have a deeper look into it, sometimes you see that it's just buzzwords. And they have a vision, but they don't really have an action plan yet. And I must say that it's not easy to organize patients together. And it's not easy to transform their patient experience into policy recommendations or design thinking or being in patient journey debate, whatever. So I really think that we should involve them much more, but also invest in them, in skill building, in making them equal partners to be sit around the table at an equal chair, let's say, because they are the most important one. They are the end users from all the products and services, and I really feel that we tend to forget that easily.
Right. Get over-focused on the treatment and not the person who's being treated.
Yes, and there's such a big mismatch sometimes, and it's now when I look back at my own patient experience that is still ongoing, although because it's a roller coaster ever since. When you look at it with a clear mind, you can easily say what the needs are, and you can understand that a new product or a new app is not really matching our needs. And it's very important to connect the dots and to give those needs to the policymakers or to the designers or to the engineers or to the ITers, whatever, to make sure that they adapt their products and services to our needs. And this is something that I'm very driven to do now because, Yeah,
it's really interesting. There's a lot of buzzwords and a lot of folks talking about this stuff, but it sounds like on the ground, there's not a lot of it actually fit for purpose or really made with the patient in mind.
And there's a lot of empty boxes. You know, they talk about patient participation, patient and like all these things, and it's really empty. And I think it's also our responsibility as the patient and the community where I'm in to take a step forward and to raise up our voice, but we need to be given the platform to do that. And I think this week is a great opportunity for me to do that and to set the example and to inspire everybody and to get inspired. And at the end of this week, I really hope we could co-create in the future, and we could collaborate. And I really believe that more patients will join this bigger movement when they see that they're being taken serious. They are being treated with respect, because sometimes that's also difficult, because the word patient is very negative and you go through a very negative experience. So also to get a very positive mindset after that experience takes some time, takes some healing. So also that needs to be given some attention.
For sure. And how does that engagement of both patients and their wider sort of group of stakeholders, their wider support system, does that link ultimately to better outcomes?
For sure. I think that's the way forward. Although it takes a lot of time and a lot of patience, I'm the first one to say that our community isn't the most easy one. As I said, with the Big C, the first step is to bring people together. And after you win their trust, then you can go forward to them and you can expect from them to give input and to be part of something bigger. But at the beginning, you really need to put a lot of time in community building, empowering them, giving them the right skills, giving them trust, giving them meaning and purpose again and identity. And I feel that that's a big step that we always forget. Like, we look for patients, we want to bring them in a patient group, and that's it. No, that's not it. It's a longer journey, and I really believe that when we take that journey and we let ourselves drive by patient innovation and we do like human-centered design thinking, this is something where I believe, and I will talk about it tonight, then the outcome would be so much better and of much more quality. Because I believe that right now, the patient journeys and the patient contribution is not at the highest level yet, and it could be much better. And then the outcome, I think a lot of beautiful things can happen then.
Right. I think we move forward in terms of technology and our treatments, but we didn't necessarily keep up in terms of how we treat the person being treated.
Yes,
right?
And we're still humans, and we cannot forget that, because we're still humans with needs, with emotions, with feelings. And being a patient means that you've been threatened by some life-threatening events, actually. Like for me, I got the diagnosis where my prognosis was 5 to 10% survival chance. That's a lot to take in.
Yeah.
And although I was cancer-free after 6 months with the best treatment ever, the fear of relapsing was always there, and that fear really needs to heal as well. You need to go through a certain coaching and healing, and this is something very important that we all forget, because we're human beings, and if we don't focus on that first, I think we're forgetting what healthcare is really about, because we're always talking about optimizing healthcare. But that's not only making sure that I survive, it's also making sure that my quality of life is guaranteed.
Yeah.
And this is something very emotional for myself, because even after 5 to 6 years, I struggle a lot. There's a lot of discrimination for me, and nobody looks at me as a human being, because I'm still a number in the hospital.
Right.
Yeah.
Right. And that fear still exists, right?
And the
you had
fear
to face
still
it,
exists, yeah.
And it's still there.
I went from every 3 months checkups to every 6 months. But imagine 1 week before, when you see that in your agenda, the control is coming, the checkup point, you kind of like lose sleep and you start thinking the worst case scenarios, and nobody's there to guide you. Your peers are there, like your community is there, which is the best medicine ever. I believe my community more than I believe my doctor. If they tell me, Stephanie, you're going to be okay, I'm like, okay, we're good. But 1 week before the checkup, the fear is there. You're not productive anymore. You're not really able to work and to think clear. Then you have your checkup, and then you need to wait 1 or 2 weeks for the results to come. So you lose like 3 to 4 weeks sometimes just trying to deal with the word cancer and the fear of relapsing, because it's there and everybody knows it's there. Like cancer is one of the biggest diseases people are scared of, and it hits all of us nowadays, unfortunately. So a lot of work still need to be done on that.
For sure. So I know we've got to let you go, so you've got to get ready for your keynote.
Yes.
What can everyone expect from your keynote presentation?
It's going to be the raw behind the scenes. It's going to be my story, very authentic, very emotional, but also very positive. It's going to be about innovation, about rehumanizing healthcare, about passion and purpose, and also about patient-driven innovation, of course, because that is what I truly believe in. And I believe that that's the missing puzzle in order to really go to that future-proof healthcare. And when we connect the patient needs or the end user, let's not use the word patient anymore even, because we're users of services, healthcare services, and when we connect our needs to the innovation and the creativity of all the designers, I think we're gonna see amazing things coming, because I'm very excited to look around here and already see how future-proof all these corporates and these organizations are already. So they can expect a lot of inspiration and a call for action.
Amazing. That
Yeah.
sounds great. Stephanie, thank you so much for joining us. Thank you for your time today. We really appreciate it.
Thank you.
Joining us now.
Well, we're going to talk about digital transformation and mainly also how we can overcome the obstacles that are facing us. And when you talk about transformation, you talk about resistance to change, how you can implement electronic medical record inside the hospital or also outside the hospital, the whole chain of command. Within the hospital, you need to train and make sure that physicians, but also nurses, secretaries, other type of healthcare intervenants accept the change. And that's mainly what we're going to talk about. There's been a lot of discussion recently about physician burnout, but also nurses burnout. And how, to some extent, is the electronic medical record or the digital transformation being responsible for this physician burnout? This is one of the topics.
I mean, it's really, what you're saying, Philip, is really interesting, because you touched on the key point here, because some people think, and I think this is why we got into some trouble with the deployment of electronic medical records, that digital transformation is merely the translocation of a paper record onto an electronic record.
Correct.
If it were only that, it wouldn't be as much of a problem. But what it entails is a complete redesign of all the pathways. So the level of engagement, the level of acceptance, the level of input needs to be enormous. So how are you managing that? Because you have, and you're thinking of moving into the community with this.
Yes. Well, you need, I think first, you need obviously a clear plan. You need to have the general management of the hospital convinced, and this should be actually their project. It's not only, like you say, Charles, implementing a new electronic health record. It's about profound change of culture within the organization. Then you need to have enough people to deploy that, and you need to make sure you have people that can train them, that are good in education, in pedagogy, all these things. I think this is really key. And then you need to make sure that the physicians, the nurses, they actually own the project and they are involved as much as possible, because it's a lot of change. And for example, in our hospital, we are stage 6. We're going to, at the end of this year, going for recertification of 6 and then for stage 7 at some point. But we have deployed all the functionalities. We are now finishing the deployment of computer order physician entry. So all the drug, which I think is the most complex part, because you need the physician to prescribe, you need the pharmacist to check, you need the robot to prepare the drug by single unit, and then you need the nurse to deliver it. So it's a lot of change. And we are in a culture, you know, in our hospital where in a lot of cases the physician would just give an oral order and then sign later or sign something. But with the computer, it doesn't work this way. If I said today at noon, well, let's give that antibiotic 3 times a day. Well, this is noon. What are we going to do today? What precise time are we going to start it? And if it's an IV drug, how is it going to be diluted? All this needs to be very precise. And the same, obviously, and probably more outside the hospital.
Yes.
Is there a place where you think they're further ahead on this transformation? And if you think that, what have they done differently?
Well, I mean, obviously the places that have reached level 6 or 7 in the MRAM scale are further than others. I think they have started a while ago. They invested money and human resources and as I said, they have a clear plan. We had a clear plan when we started. Now, to come back to the physician burnout, I wonder sometime whether it's the medical record itself which is responsible for that, or the old regulation that we put. For example, in the US, you have so many things that you need to enter in the medical record, not necessarily for true patient care, but because of all the process that you have to document, because you fear a lawsuit, because there is reimbursement and billing issues. What do you think about that?
Well,
Charles?
I mean, I think you're absolutely correct. I think it's multifactorial, and the phrase you hear, the phrase we hear as we go around the world is we're being asked to do more with less in less time.
Correct.
And really, though, that is basically what tends to happen, because inevitably all the care gaps become extremely important all at the same time. So suddenly people are faced with a sea of red flags. Then all the administrative gaps, which are important, often associated with payment, have to be filled in. And a simple conversation, or rather a complex conversation about an individual and their knee, for example, turns into something far bigger.
Yeah.
And it's got 10 minutes to do this, the physician. Of course they're pressurized.
Yeah.
Correct. Now, if we move to patient care outside the hospital, which I think we really need to invest more there, because the population is getting older, because we have these patients are having more comorbidities, patient with chronic heart disease, chronic lung disease, diabetes, end-stage kidney disease, whatever. And there, we also need to convince the politicians that the model of financing healthcare needs to change and to evolve. For example, in Belgium, and it's the same in France and in Germany, for example, we are financed according to a particular diagnosis and a national average length of stay. It's called what justified beds, but for what we do outside the hospital, it's tiny, it's almost nothing, it's mainly research project. And if on one side we need to shorten the length of stay of the patient because stay in the hospital is very costly, but we also need to be financed to follow the patient outside the hospital, together with the GP, obviously.
Oh, yes,
but
yes.
there are things that the GP cannot do.
Yeah.
And this is something that is very slow.
Right.
I'm sure you're facing the same problem in the UK.
Well, I don't think it's only the UK. This is a global issue. The move from volume to value is something we're all in the process of going through. It's painful. And what we haven't done, of course, is we haven't kept the metrics in the place where they should be. We still have metrics which basically measure volume and then expect value out of our health systems, and then wonder why we're not getting value.
Right.
Because we're only rewarding volume. I mean, it's pretty damn obvious.
Yes, yeah, but at the same time, there's this massive rise of wearables. Do you see a role in sort of patients taking on some of their own data, some of their own personal health information as being part of this transformation?
I do. I think that this data that come from all the devices are extremely valuable, right? Especially, again, for the chronic patients. Now, the thing is, the question is, what do we do with this data? Because they're enormous in terms of amount. So again, it's not a problem from a technical point of view to have this data move from your watch or your wearable device to the computer somewhere, but then what do we do with it? We can have algorithm, but then at some point we probably need human resources that will decide, are we going to call the patient to find out how he or she is doing?
Yeah.
Do we need to send a nurse to the patient? Do we need to call the patient to the office?
And I mean, we made quite a few mistakes when we're first deploying these, because we deployed them as pilots globally. We didn't think enough about the governance, which is really what you're talking about. And what we've learned is, if you are going to deploy something, you have to build in the governance at the same time you're deploying it.
Yes.
Because that governance is fundamental. At 3 in the morning, if somebody has an arrhythmia, who do you call? Who?
Yeah.
What if they're on holiday?
That's right.
Who?
And what do you do with that data?
What do you do with it? Yeah.
Yeah. So in the last few minutes, Professor, why don't you tell us a little bit about what you're excited to see this week at HIMSS?
Well, I think I'm thrilled to see the evolution of HIMSS in Europe. I think when you look at the size of the event in the US, 40,000, 45,000 people attending Orlando this year. Here, we used to have, less than 2,000, 1,500 people, and here we heard yesterday from Hal Wolf that we reached 2,850. We may reach 3,000. I think this is great, and I think we need to develop HIMSS in Europe a lot, because that's unique interface between the healthcare providers and the industry, and there is a lot we can learn from that. I'm thrilled by the quality of the speakers, the amount of sessions, the content of the sessions, the exhibition hall, and I'm really learning a lot, and also obviously by meeting and discussing with the colleagues and peers.
Sounds great. Professor, thank you so much for joining us.
My
really
pleasure.
appreciate it.
Thank you for the invitation. Thank you.
So I think the one thing we talked about there, which is really interesting to me, is this idea of physician burnout. And I wonder if that's sort of a worse in the short term, and then it gets better once we get all of this stuff implemented. What do you think?
I think it's going to be a journey which is very rocky.
Right.
I wish it was as simple as we have to get through this little hump and then we're okay.
Right.
Because a lot is in the implementation. If it's implemented correctly, an EMR could actually act as a physical and clinical extender. But sadly, we tend to implement it all too often in a way whereby we add to the pressure rather than reduce it.
No, I think that's true. So joining us next is Saif Abed, MD, and founding partner, Abed Graham Healthcare Strategies. Welcome. Thank you for joining us.
Well, thank you for having me.
We're really excited to have you with us. To kick off, why don't you tell us a little bit about your session this week here at HIMSS Europe?
Yeah, I'm really excited to see cyber on the agenda to begin with. It's really about engaging healthcare leadership from multidisciplinary backgrounds, getting them to just think, what are the issues that are going to face healthcare organizations from a cyber risk perspective, whether that's government agencies, their supplier relationships, or as clinical organizations in their own right. And really exciting, we're going to run an interactive wargaming exercise as well, really getting people to come up with some worst case scenarios, but also how to stop them.
I think that's great, absolutely awesome. And cyber has really come of age. And why has it come of age? Well, as the multitude of players increases in the delivery of health and care, the days when only one person was responsible for inputting data has long gone. So the potential for disaster has increased, and also the sophistication of attacks has increased. And I think now it's everybody's business.
Very much so. And sometimes I have to ask the tough questions. For example, you see things like interoperability and integrated care. That's what we want to achieve. But what is the risk that comes with that? Are we going to connect up insecure systems altogether? That means once a bad actor gets in, they could take down the whole system.
Yeah.
Unfortunately, we have to ask those questions, not to hold back progress, but to make sure cyber doesn't get in the way of progress. So we want to address questions like that today as well.
Yeah, and I would imagine the problem gets worse and worse as we get more and more and more data. And the idea that we talked about just a few minutes ago, with including wearables and sort of patient-controlled information, there's your sort of loose ends, right? And how you get into these systems.
Very much so. As you see, the digital fabric has major, large technology companies, but you have this startup ecosystem as well. They need to play nicely side by side. But actually, what's really interesting is both are equally immature still from a security perspective. And what I'm trying to get them to think about is, don't think about it as a technical problem. Think about it as a clinical risk problem. What happens if an attacker tampers with an e-prescribing module and medication data, medical imaging? What if they just mix up referral letters? Those kind of very practical, visceral examples, they get the conversation going.
Yes, and I completely support that, because over years I've tried to get clinicians interested in cybersecurity, because I think it's everybody's business. But in the beginning it was really quite difficult, because people felt it was somebody else's business.
Yes.
But the moment you talk about the potential for actually transposing a medical record or transposing a clinical record for medication, people go, oh, no, we can't have that.
Yes.
And that's actually quite helpful, because then they engage.
We have to make the conversation visceral.
Yes.
As a clinician, myself, I have a clinical conversation around cyber with my peers. When I speak to technical people, I have a technical conversation.
Yes.
When it's at the board level, have it at a financial level. So we need to understand that cyber isn't just the CIO's problem. It is everyone's problem, as you say, but we need to make sure we're all speaking a similar-ish language so we understand the problem and can come up with solutions together. And again, that's a big goal of today's workshop. Get people from different backgrounds, different perspectives, talking. It's good to talk.
Right. Where it's such a big problem, right? It touches every part of a clinical practice. Where do you start?
And that's a really good question. I've been fortunate to be able to work with government agencies as well as suppliers and healthcare providers. And I do think there is an element of significant responsibility on the policy side, but the policy side has to come with a carrot and a stick. We can't just continue to issue non-binding advisory guidance.
Right.
We need to be a bit more tough centrally, I would suggest, across Europe around this. I believe the supplier community needs to take greater responsibility. They are putting the solutions out there. They should be having the clinical risk conversation. There are standards for those. And I think for healthcare organizations, there is a responsibility at least to start hiring people with the right expertise and background, even if it's just one person, to start addressing cyber as a full-time occupation. We all know that healthcare organizations are stretched, but if you can address the HR issue, then that's an incremental and positive step forward.
And really, we had a couple of instances, and the one that comes to mind, of course, is WannaCry, because that was the celebrated incident, which really showed how important it is to think about cybersecurity, because the business continuity that followed from that, the loss of income for the organizations, significant reputational damage to the organization, and that's before the potential damage to people even starts to be factored in, was significant enough for people to say, this can't happen again on my watch.
So I'll tell you, a pet peeve I have around that is people say to me, well, can you show me a patient that was harmed?
Oh yeah, I can.
Well, I'd love to hear that.
People who haven't had operations, people who've died waiting for treatment.
Well, see, that's the one. So I say, for example, if you're a stroke patient in an ambulance, you have 3 hours to be seen. If that ambulance is diverted and it's another 20 minutes, every minute counts. That's the difference between being paralyzed on one side and having a full recovery.
Absolutely, especially if they go to a hospital that's not accredited as a result. There's no doubt at all.
Exactly, and but here's the thing, we have to ask the question, are the government agencies and the IT suppliers fully aware that that is the end result of a cyber issue? Until they are, then the right steps won't be taken to address the issue. So it's incumbent on us as a community, health IT, and as clinicians to be interested in taking this conversation to where it needs to be.
Well, and bringing it to the clinician level, is there an element of education here? Is that if I went to medical school today, will I have any courses at all in cybersecurity or managing data or GDPR? Like, will these things even cross my mind while I go to medical
Perhaps
school?
I sound very cynical. I think given WannaCry only happened in the last few years and the industry is only starting to look at it, I think we're very far away in terms of the medical school level. It would be great to have even just an elective module on it.
One course.
But I think one of the things we have to consider is, and this is an interesting paradox, we have a more digitally savvy younger generation of clinicians coming through. That does not by default mean they are more secure.
No.
In fact, it might mean they're using more systems and they feel a greater full sense of security.
Nursing education, healthcare education, because it's all of us, of course, who are involved in this process, is one which I think is coming to the stage where it will be implemented. I think people are now starting to be worried enough about the danger of having this discontinuity of business that they are going to be moving in this space.
I certainly hope so.
So, healthcare changes by catharsis, and by God do we have one. So it's great.
yes, and I find it very positive, and I find it very exciting. The one last point I will make, I suppose, is that the healthcare community is still immature in terms of cyber, but taking gradual steps. But the cyber community is immature about healthcare. So there needs to be a meeting in the middle. So we need to educate both sides.
Right.
Maybe the health IT community can educate the cyber community and vice versa.
Yes.
If we can get that conversation going, we'll start getting good results.
Yeah, that's really where I think it will all come together.
Yes.
In the few minutes that we have left, why don't you tell us a little bit about what you're excited to see this week here at HIMSS Europe?
Well, obviously, I'm biased towards cybersecurity.
course.
I want to start having a bit more probing conversations with the supplier community, see how they're addressing things. I think I want to see issues like AI and 5G and mobility. I want to see who's really thinking about those as suppliers. Again, from a security perspective, but also in terms of how it's going to affect the delivery of health IT services and augment it. I think, again, interoperability is going to be high on my agenda. I want to see who's thinking about it, what pilots are happening, a bit of security on that. But yeah, I'd say mobility, interoperability, AI. Those would be the 3 innovation areas I want to hear more about.
Fantastic. Thank you so much for your time today. We really appreciate having you with us.
Thank you.
Great. Thank you for having me. Thank you.
That's great. Thank you so
very
much.
Thank you.
So next we're going to hear from one of our EC2VC winners. Let's roll the tape, guys.
Hello and welcome to HIMSS TV. My name is Leontina and I am an associate editor for HIMSS Media, and I'm here with Wojtek Radomski from Stead.me. Hello and welcome.
Hello.
Thank you. So we just attended the EC2VC competition, and Wojtek is actually the winner in the seed category, so congratulations.
Thank you very much.
So tell us and our viewers a little bit about your solution.
Sure. So we are working on smart stethoscope. Our idea is to put this tiny device in every home. So whenever you will have any problems with your or your kid's health, you will just put the device on the chest. It will record the sounds, and our AI will analyze the sound and provide you instant feedback what's happening. So based on this analysis, the doctor also will receive a detailed medical report. So using telemedicine solutions, you will be able to have a diagnosis without leaving home.
Right, that is very interesting. And you actually pitched today, as I mentioned. So what did you think about the other solutions that were presented?
Well, all of the solutions were very interesting. These kind of the solutions, I think, are building the future of the healthcare. So they were all selected by the jury to present in here, and they were bringing a lot of values to the patient.
And what did you think set you apart?
Sorry.
What do you think set you apart from the others?
I think that the fact that we are focusing on the very important aspect of the healthcare, which is primary care, and as I pitched, there are even up to 70% of visits that are unnecessary. So this is not only savings for the healthcare system, but this is also a very useful for the parents and for ourselves. So we do not have to travel back and forth to the doctor, as we have tool in hands, certified tool, because it's important to add that recently we, as a first company in the world, received CE certification for this solution. So thanks to that, you have an important tool at your cabinet, and your doctor is at your hand.
And obviously the challenges that you mentioned are putting increasing pressure on healthcare. So where do you see the digital health startup scene headed in the future? And is there anything that you'd like to see more of?
Yes, I think that we are heading into times where we will have more and more devices at home, and those devices will generate a lot of data. This data in next few years will come to the normal doctors, and they will have to analyze that. But because the number of the devices will grow, the number of the data will grow as well, so they won't be able to analyze all the data. So this is where AI is important, which will be able to automatically analyze those tons of data and select the ones which are only important for the doctor to make the consultation.
Very good. Thank you and congratulations again.
Thank you very much.
Joining us next is Raja Sharif, who's the CEO of Pharma Trust. Raja, welcome.
Thank you.
It's great to have you with us. Why don't we start off by having you tell us a little bit about your session here at HIMSS Europe this week?
So we were speaking about blockchain and its relevance to the pharmaceutical and healthcare sector. Pharma Trust operates in 3 verticals. We only specialize in the healthcare sector, actually. So we do supply chain tracking and data services. Personalized medicine, that's cell and gene therapy or stem cell therapies, and clinical trials. And everything that we do is underlined by blockchain system.
So for our viewers who aren't familiar or who are still trying to wrap their head around blockchain, can you explain what blockchain is and how you apply it to healthcare?
Yeah. So in very simple terms, blockchain is a recording of transactions in a chronological order. So you have one block, then you have a timestamp on that, and then you can add to that block with another block, and it's time stamped. So what that means is the data becomes immutable and incorruptible. So you know exactly who had what, when they had it, and depending on what kind of sensors you use, what they even did
And that
to it.
obviously has a natural application in supply chain management, for example, right?
Absolutely. Supply chain management is one of the best uses for blockchain, I would say, apart from the cryptocurrencies that people will know about. People need to distinguish, of course, between cryptocurrencies like Bitcoin and blockchain as the infrastructure behind it that allows it to work. Essentially, the important thing about blockchain is that it allows for data integrity. Once you've written it, you can't change that data.
Yeah.
And that, of course, is very important for a number of processes. It's great for AI and data analytics. It's great for regulatory reporting because the regulators are comfortable that the data hasn't been changed. And, of course, for public confidence generally.
Right.
You know, there is complete transparency and unalterability of that data.
Right, and it's also really good for managing very large amounts of data, right?
Well,
Or
not
breaking
yet.
them into smaller bits.
The blockchain doesn't lend itself very well to storing large amounts of data right now.
Right.
It will be in the future. At the moment, it's more important to record transactions which are put into hashes. So things like patient data or pictures
Yeah.
or very data hungry kind of applications don't work so well on blockchain so far.
Right.
However, they're very good at recording transactions, the sort of stuff that we do,
Right.
which is I give you something. We know what time you got that. We know who gave it, when we gave it to you, and how long you had it.
Gotcha.
And the great thing about blockchain is, of course, also that it's very secure. The whole system is based on cryptography. So a lot of people worry about security, but we would say it's actually more secure than any other system out there
Right.
currently.
And it gives you better transparency on the data that's being stored, right?
Absolutely. So, you know, depending on what kind of blockchains you use, there are permission blockchains, which are private consortia, usually on nodes, and there's public blockchains, which everyone knows as the Bitcoin network or the Ethereum network. We tend to use hybrids. So we have a mixture of permissioned or private blockchains, and sometimes where our clients require it, we also use public blockchains depending on the needs of the client. The reason you would do that is you get the speed and scalability on the private blockchains, and then sometimes for regulatory reasons where regulators are concerned about data being changed, we would post summaries onto the public blockchain depending on our clients' needs.
Right, but that transparency is really what attracts the regulators, and what I'm sure is helping to drive real transformation within healthcare.
Absolutely. We tend to find the US FDA is actually far ahead of most regulators in terms of inviting trials. We're actually part of a US FDA trial for blockchain data interchange with the consortium partners such as T-Systems, Systech, and CryptoWorks, as well as RFXall, and they want to be, or we want to be in a position to show the FDA that you can transfer data from one platform to another. And that's quite important to PharmaTrust as a company. We tend to take a blockchain neutral approach, a technology neutral approach, and a sensor neutral approach. The rationale being that in the pharmaceutical industry and the supply chain generally, you tend to have a lot of systems, even within companies.
Right.
And our system is very good at taking data from different systems and collating it onto our blockchain system.
Right.
The other thing is, of course, it's a nascent technology. So we use the example of the late 1990s with the search engines.
Okay.
So you started off with MSN Explorer, then
Yeah.
Netscape came, and then you had Ask Jeeves, for example, Yahoo, and then, of course, Google came along. We believe blockchain is still evolving. So what we do is we use GS1 standards and EPSIS standards to make sure we can move data around from different platforms depending on what the client's needs are, and future-proofing their systems.
Right.
So
right.
our whole thing is about digitizing and future-proofing clients' systems going forward. And there are IoT sensors now that will only work with blockchain
Right.
because of power consumption and size requirements.
But it sounds like being sort of platform agnostic, if you will, is a way of ensuring that as you move forward, it doesn't really matter how many different types of data, how many different systems you have to interact with, you're kind of future-proofing the technology. As you say.
Absolutely. So, you know, blockchains themselves are improving, they're becoming more scalable, they're becoming faster. Different types of blockchains are coming out, and different companies are announcing their own blockchain.
Yes.
So, you know, recently you've had AWS, you've had Oracle as well. IBM, of course, have had theirs for a long time. We're, in fact, the Oracle Healthcare lead for their retail blockchain consortia, but we also partner with IBM equally. And some may feel, well, you know, you're not taking a vote of confidence in a particular blockchain, but our view is we need to stay neutral to best serve the client's needs. And to encourage the use of this technology, we need to de-risk it.
Yeah.
So it's a brave CTO that says, right, I'm going to put all my eggs in the MSN Explorer basket,
Yes.
and then of course Google comes along and, you know, they're in trouble. So what we do is we de-risk it by allowing you to be able to hop between blockchains, and B, you know, being technology agnostic as well. So it becomes so much easier for businesses to actually adopt blockchain and feel more comfortable with it.
Right, and it's that comfort level that I think is really a challenge today, right? You know, anytime I talk to anybody about blockchain, I always like to ask, is it a game changer? Is it just hype? Or is it somewhere in between? Are we just not quite there yet in terms of our understanding of it?
I think understanding is a real issue, but it's become, I think the education process has become so much better this year and the latter part of last year. When we first started off at the back end of 2016 and the whole of 2017, a lot of people were talking about ICOs, cryptocurrencies,
Yes.
dark web, money laundering, etc., etc. But what we found, and the Deloitte report confirms this, it came out 2 weeks ago, that 85% of senior executives see blockchain use cases as quite important. 53% of senior executives have now made it a top 5 priority for their companies.
Wow.
So it's very important for people to get an understanding of blockchain, its advantages, its drawbacks, and different ways you can use it. Of course, blockchain's not going to solve everything. You know, and that's the same with any kind of boom type of technology. You know, they promise you the earth. But for healthcare and pharmaceutical needs, and particularly in the supply chain area, we think it is a game changer. It does allow real-time reconciliation of records. It does allow that transparency. But more importantly, where there are a number of players in the supply chain, with blockchain, you can control who sees which bits of your data.
Yes, yes.
And that is actually fundamental in a kind of a non-trusting environment between competitors.
Right, and keep all of those transactions in order, of course.
Absolutely.
Do you think that sort of, it was almost felt like a bubble and a burst cycle in 2016, 2017 with cryptocurrencies. Do you think that hurt the application going forward of blockchain or helped it? Like, did it get just more eyeballs on it, more understanding of it, or did it hurt it because it sort of felt like this bubble that blew up and then burst?
Yeah, so I lived through the dot-com boom and then subsequent bust. And I remember when I was first involved in technology, I had lawyer friends in banks saying, look, this will never catch on, it's not secure enough, you know, banking never lends itself, it's a very regulated industry, it's not going to happen. Now, of course, as you can see, everyone does their banking on their smartphone apps. I think the boom and bust was actually advantageous from a knowledge perspective. It did make the technology much more aware to people who wouldn't otherwise have investigated it. I think it took a lot of bad players out, and it was also a good education perspective for people to understand who they can trust and who they can't trust.
Right.
And we hope to be one of the kind of startups that lived through that bust.
Right, right.
You know, we've got clients, our systems are operational. So, you know, depending on the size of the supply chain, we can actually come in and install within 4 weeks in a particular product line. We've got various data dashboards which help different parts of your clients' organizations to understand the data that is coming through. And of course, remember, remember, the important thing about blockchain is data integrity. It
Right.
gives you access to good data, which allows you to make better decisions and faster decisions because you're getting real-time data.
Of course, of course. So we only have about a minute left together. Unfortunately, this has been super interesting. Before we wrap, can you tell me what you're really excited to see here at HIMSS Europe this week?
HIMSS is actually really interesting because it brings a lot of different companies from different parts of the healthcare industry together, and that of course allows us to talk to different people, be they ones involved in IoT, artificial intelligence, which is quite important for us because we want to get to the stage where we can tell our clients what to produce, when to produce it, for which territories, in what quantities, and that will really bring a lot of efficiency to the pharmaceutical industry. We also work in the personalized healthcare or cell and gene therapy, which, as you know, each treatment costs between $400,000 and $1.2 million each. The technology we've brought in allows you to fundamentally guarantee the quality of each treatment, but also allows you to keep the regulator happy because you only have 20 days to produce these treatments. And you know, the regulators demand that there's a full and accurate and permanent record of who did what to that treatment.
So another
for
great
consumer.
application for your technology.
Absolutely, and the future from our perspective.
Fantastic. Roger, thank you so much. This was
Thank
great.
you.
We appreciate your time.
Now we have with us Päivi Silanauki, who's the Permanent Secretary of the Ministry of Social Affairs and Health.
Good morning.
Welcome. And what a wonderful welcome to Finland. Incredible sunshine, a long day, and warmth. This is fantastic.
We have really carefully planned this.
And more importantly, warmth from the population. So thank you very much for everything, because this is a wonderful venue to have our conference. So I just wanted to have a conversation with you really about a couple of things. Finland is really quite special, really. It's special in a whole host of places. It's special in public health, going back to Karelia. It's special in its relationships between government and population. And, you know, globally, people look at Finland and really aspire to having the relationship and level of trust you have with your population. So could you talk to me a little bit about how you got there?
Yeah, that has been an incredible journey during last 100 years while we have had our independence. Politicians were quite clever then and wise when they decided to invest in people. And in Finland, we have a taxation-based welfare society, where everyone is then and has possibility of free education, social and health services they need, and all the support, social security also. So that is one reason, and I think the most important reason for why people really trust government, because government has worked for them and made it possible for people then to then show their capabilities and be part of the society. We have also collected systematically data, health and socioeconomic data from people for decades, since 1960s. And of course, this is sensitive data, but we have used the data to make people's lives easier. So that is also that people are willing to give the information for the government use. And then we have kept that promise then to handle the data in a secure way, so that there is also regulations and people can trust that no one who is not allowed to see the data doesn't see it.
It's fascinating because in many respects, in terms of the processes, a lot of countries have tried to do the same, but they haven't been listened to quite as much as by the population as you have. I mean, a real example of that is MyCanta. You have a system which is universally used. in a lot of countries, people have felt so worried about this that they have actually not wanted to be part of the process. But you've managed that. I think there must be something really more intense about the relationship. You've managed to actually manage that relationship with your population so much better than a lot of other countries have. And I think you've done that even through some big reorganizations, because you're going through some reorganization at the moment.
Yes, we are going. Actually, already 4 governments have tried to do a major social and health service reform in Finland. Of course, we have proceeded all the time, but it is hard for politicians to really change and reorganize things. We are aiming to have an integrated social and health service care and a structure. And I think that is a good plan, because now when our population is aging second fastest in the world, did you know that?
Yes.
So yes, and there you have to then combine services and social security and other support. Then you have to be able to have smooth care and support processes. You need both data from socioeconomic data, but also health data.
So, I mean, it's absolutely incontroversial that you need health and social care to work together. All the countries in the world aspire to this. But I wouldn't beat yourself on the head so much in terms of the difficulty of actually getting structural reform sorted out. As you can tell from my accent, I come from England, and we've been trying to do that for the last 50 years, and we haven't quite managed yet. I don't know how many governments have had difficulty with this, and I think there's an element of inevitability about it. And you're also soon coming to your presidency of the European Union. And what an opportunity that will be. Is it going to be a showcase of your experience around aging? Because you also have something to say around that as well.
Yes. We'll be focusing on aging, of course, and try to do a mindset change there. We are having a big conference in the beginning of July called Silver Economy, where there is a economical, financial, technological, where we have the digitalization and new technology, but also well-being aspects on that. Not only seeing the aging population as a burden or challenge for countries, but also all the potential we have there.
Yes.
Having well-being, long-living people there. So there are a lot of potential also for that. That will be a global conference then. Then our major themes in health sector are then economy of well-being. We will also try to have a good conversation on what kind of impact health really has on sustainable economy, sustainable societies, security, but also for innovations, new technology and growth for Europe. And then, of course, we want to have, and that's why I think that it's important that we have also HIMSS now here, is that we want that Europe will be in front when the new technology is developed.
And you're right on the button in terms of aging, you're right on the button in terms of productive, healthy aging, and you're right on the button insofar as the only way you can really drive this is through digital technologies using precision, predictive, personalized prevention, because that's basically what you're talking about.
Yeah.
And what a place to do it in, Finland, the place which really started the public health journey in many respects many years ago now. So this is a wonderful opportunity, I think, around aging, and I hope that people come to that conference, because it's really quite an important conference, but also the outputs of that conference are transmitted globally, because they are certainly needed. And what are your aspirations as to our conference here over the next few days? What do you feel would be some real achievements coming out of them?
I'm very excited and very glad that we have this opportunity to be here in Finland with HIMSS. not only this year, but also
Over the next few
coming over
years.
next few years. And I would like to then collect experiences here to be even better than next year. But we have a wonderful program for these 3 days, and let's learn by doing and see then what we have achieved. Together we are strong.
So that's the tagline. Let's learn by doing, and let's learn by doing from what we've seen here over the last few days. So thank you very much for the opportunity.
Thank you.
Thank you.
Joining us now is Paulette Cobb, Head of Global Strategic Marketing for Healthcare Informatics at Philips. Paula, welcome.
Thank you.
It's such a pleasure to have you with us. So we understand that Philips has just announced the Future Health Index 2019 report. What is the Future Health Index, or FHI, and what are some of the recent results that would be most relevant to our HIMSS Europe audience?
Absolutely. Well, the FHI, or the Future Health Index, is really a survey that we sponsor that allows us to explore what's happening in technology within healthcare systems. How is it being adopted both at the patient side as well as the professional side, and really understanding across the globe where we have the opportunity to improve the use of technology and understand where and how it's being accepted today.
Oh, that's really interesting.
And on that, are there any key emerging countries that more developed countries can learn from, Paula?
Yeah, so as we've been doing this index, what's really been interesting, we started to see a trend where we felt like some countries were actually going to be able to leapfrog others. And we've certainly seen that in China, Saudi Arabia as examples, in India, where they truly are embracing, adopting health records and digital healthcare much faster than some of the others and accepting the technology trends. So it's really fascinating to see, and look into some of the reasons why are behind that.
Definitely. And so what can delegates expect to learn from your Philips booth here at HIMSS and Health 2.0?
Yeah, well, we're very excited to be here at HIMSS. Obviously, we have such a strong portfolio of solutions across the health continuum. We'll be showcasing a lot of our connected care solutions as well as our end-to-end enterprise digital imaging solutions. So we have things like telehealth. We also have our TASI solution, which is our EMR solution. We have many other capabilities that we'll be sharing with all of our visitors this week.
So some people may not be aware that Philips has this TASI solution that's expanded into the European market. Can you tell us a little bit more about that?
Absolutely. So we have been in the Brazil market for many years, and we do have a full end-to-end EMR solution that's being utilized by over 1,000 different customers. We've been expanding it across the globe for, I guess, the last 4 or 5 years. We're now available in Australia, New Zealand. We're also available in Germany. We are partnering with companies in Poland, Japan, and other areas to bring this capability. It's a cloud-based, fully software as a service EMR solution that is extremely flexible. We push out releases and capabilities to our customers every 2 weeks. It's very affordable. Our satisfaction with the physicians is unbelievable. We're very proud of the solution and so excited as we continue to look for new countries to bring it into the market.
That sounds amazing.
Sounds great. So can you tell us a little bit more about the additional health IT solutions that you're adopting across Europe?
Yeah, absolutely. So, end to end, we're bringing solutions like oncology informatics. We also have our telehealth and EICU solutions. Philips' goal is really to take a lot of the burden from the health systems and bring in capabilities that are software as a service, that are outsourced capabilities where we can manage the technology and just let the hospital system focus on some of the core issues that they face, like cybersecurity and things of that nature. By us managing and helping them with the managed service of the solutions, it really gives them a lot of value to focus on the right things.
Yeah, it's great to see software as a service sort of coming to healthcare, right? In our business and digital media, it's been around for a long time, but it's, I think, a different approach than a lot of other companies are doing.
Yeah, it's amazing to me because, as you're right, it's pretty common in many industries, but it has been slow. There's a lot of regulatory requirements that made it a challenge for many health systems to be able to leverage it, but those are changing, and we're seeing a rapid switch to that. I think a lot of it, too, is the pressure that we're getting with the cyber attacks across the globe within healthcare. They're coming after us, so we really have to work together, find new models in order to be able to deliver solutions in a new way and help them combat that.
That sounds really exciting. I just wanted to touch on your approach to AI. Can you tell us a little bit more about your unique approach to AI in the industry?
Absolutely. So, of course, AI is artificial intelligence, but at Philips, we call it adaptive intelligence. We believe it's important because obviously AI is a little bit scary. People think of it and they think of robots and somebody doing something where a person's not involved. Well, in healthcare, we know that that is really risky. Patients and our Future Health Index shows that even patients are a little bit skeptical and cautious about it and how it will be utilized. So we went into market with our solution saying, how do we adapt? How do we leverage machine learning? How do we leverage these capabilities for repeatable tasks and bring it in so it actually makes the clinical staff more effective and efficient, and then allows them to feel more comfortable in what's being done and how it's being utilized?
I think that talks to some of the points that were raised in Eric Topol's book around kind of increasing that patient empathy and actually taking some of the burden off the clinician to allow them to have time with, to understand the patient's symptoms a little bit better. So I think it's great. I think it's fantastic stuff, and I'm really excited about the future developments.
Yeah, absolutely. We have an example of radiologists where, he would tell us that on basic days, he has 30 minutes per patient, and he would spend about 20 minutes reviewing the images and looking at the data and about 10 minutes with the patient. So our goal in our test with him and piloting our Illumio solution was, how do we switch that? And we literally were able to give the patient 20 minutes of time and give the radiologist 10 minutes. What a value that does for the overall patient experience.
And you guys just had your first commercial install of this in France. Can I ask why France? Why was that sort of the pilot, if you will?
Yeah, well, absolutely. It's important because obviously they were willing. Having a partner and a customer that is willing to actually go through the process of what we call co-developing and co-creating a solution and being willing to put their staff hand in hand with ours to make sure that what we believe and how this should work actually does work within a clinical setting. So, yeah, it's exciting. Obviously, in France, they're definitely one of our partners. They're always willing to take some chances with us, and let's test and break the mold and try to move things forward faster.
Fantastic.
Right. I wonder if I can also just quickly, before we wrap up, just touch on the acquisition of Carestream and where we are with that. If you can talk to the time frames involved and what the next steps are.
Absolutely. So we are so excited about bringing the Carestream employees into our company and join us. The acquisition is projected to close in the August timeframe because of how many countries are involved. It will take a little bit of time before there, but we do expect everything to be closed by the end of the year. And we're thrilled to have them and their capabilities because they bring some flexibility into the imaging world that we really need in radiology that allows us to then really target some of the individual components across the work stream and bring that into new markets. It was a great complementary footprint from what Philips has, so now it allows us to really expand across the European area as well as across the world.
Definitely.
That's fantastic. Sounds like you're going to be very busy this summer, though.
Absolutely, always.
That's great. Paula, thank you so much for joining us. We really appreciate your time.
Thank you.
Thank you.
Welcome back. Joining me now is Dr. Jordi Serrano-Pons, who's the founder and chief executive officer of Universal Doctor. Thank you so much for joining us, Jordi.
Thank you for inviting me.
It's great to have you with us. What can you tell us about Universal Doctor?
Well, Universal Doctor was a company created many years ago already. At the beginning, it was a medical translation tool. We precisely developed it to improve communication between patients and doctors that were not sharing the same languages for migrants. As probably will ask me later about migrant health, I will speak about that later tomorrow. But it was the point to start to improve communication between patients and so between migrants and doctors that didn't share the same language. But slowly we kept moving. We reinvented ourselves. So we are every 2 years we are a new startup, but always with the nice title of Universal Doctor, which is very global. And basically we have converted ourselves in what we call the Universal Doctor, the global health digital company. Actually, we love global health, and we've been able to work and collaborate with many international organizations, as WHO, like International Migrant Organization, like also very specialized agency or institutes like London School of Tropical Medicine, to develop tools about mental health, for example, palliative care, or neglected diseases, which are very important from a global health point of view. So it's been a nice evolution, and we always try to collaborate with many institutions as possible, but have an impact with a digital tool that has a real impact on the field if possible.
And so you mentioned some of your work or your collaboration with WHO, London School of Tropical Medicine, other international organizations. What are some of the key trends that you've noticed around the world in your work with these organizations?
Well, the world is so big, and of course, there's a lot of variation between countries, regions. 2011, 12, 13, I don't remember exactly the year, but there was a moratorium in one of the biggest African countries to stop implementing pilots because government was afraid of too many pilots and coordinated pilots. But that has moved into a more coordinated effort worldwide. And I would say that not stoppers or barriers. On the contrary, I would say that in other countries, we cannot call them anymore developing countries. We should call them or medium-income countries or low-income countries. In some countries, the interoperability issue, it's because there was nothing. As always, the leapfrogging allows you to work from zero very quickly. So the leapfrogging, like tools like OpenMRS or OpenSRP, which is the front end of that, or District Health Information System 2, which is the data collection that collects all the data of government, of the district's health systems of the government, and then it's poured into, for example, WHO and organizations. So you have all these tools already prepared. And when you're developing a tool in these countries, you know that you will have to interconnect with these tools. So you already know exactly how to work with, no? Here and in any other countries, a lot of people have been working very hard to increase interoperability with HL7, lately FHIR. These systems work already. Of course, you also know about that. But it's been like 25 years of battling.
Yeah.
And in these other countries, it's been like just 4 or 5 years.
Right.
So the tendency is that there's a lot of things to collaborate and to converge. And I would say not stoppers or barriers, but just learnings from all the other countries.
Right, right. That interoperability and the variability of it between different countries is really interesting.
Yeah, absolutely.
So at the conference, HIMSS Europe, this week, you're going to be talking about the climate emergency and how this could potentially cause even more catastrophes in the next year, and how they're going to kind of snowball and force even more migration. So what can you tell us about this and your latest initiative, which is Chatbots for Global Health?
Yeah. No, obviously. We started our projects with this migrant health translation tool. When there was the refugee crisis in Germany, one of Syrian refugees, 2015-16, we developed a tool called Refugee Speaker. And we got involved more and more in these healthcare tools to improve the health of migrants. We've been also collaborating with international migrant organizations to add our dictionary translation tool into their app, a MIC app, a very well done work by international migrant organizations. But in general, all these tools must try to help to face this big crisis, which is the more migrants every year. Not only international migrants, also internal displacement migrants, which people forget about it, but internally in countries, massive movements of internal displaced people by floods, by other things derived from climate change. And with the climate change, it will improve a lot, it will increase a lot these numbers. And we have to be prepared to have a real medicine on the move capacity, which is not the case right now.
Right.
Lack of interoperability, lack, of course, for the same security or the lack of identity sometimes of migrants. But there are many initiatives already. UNICEF did a wonderful initiative for securing the identity of children with blockchain technologies and so on. There's a lot of initiatives that can handle at least partially some of the burdens of these refugees are facing, because the burden is so high. But at least we should be prepared and give all the facilities with these digital tools and try to palliate a little bit at least this big crisis.
Right. And I'm just curious, when we think about all these solutions, technology-based solutions, when we're thinking about migrations that might be caused by climate change, is there an element of making sure that things aren't too technical so that they can work in a crisis situation where maybe we've lost power or migrants are displaced into places or they're stuck in places where there's not a lot of access to things to power our devices to run this technology?
Yeah, actually, one of the proposals was to to implement these chatbots, no?
Yeah.
That gives what you were asking before, chatbots for global health, no?
Yeah.
Giving chatbots for informational aspects too. And of course, if there is no internet, no, the chatbots wouldn't be working at some point, no? But of course, there are a lot of possibilities with offline technologies. Once you have already how the chatbot works, how the framework, basically the questions already posed by many people and the answers required, you of course can deliver content offline, and there are many other technologies that allows you to really reach these people with no power and so on. This element, however, it's very important, and when these people are in these extreme conditions, communication is the most maybe important of the necessities. We are working in different projects, and actually in the conference tomorrow, Brian DeFrancesca, one of the speakers, will explain a huge and wonderful work they're developing in the refugee camps with telemedicine and other aspects. And there will be also some technical officers of WHO will be explaining all the big policies about the refugee health care guidelines. There's a lot of possibilities, but it's an obligation.
Right.
It's a must
Yeah.
from our side, or all the people that have the capacity to collaborate with, to at least have these elements that will palliate slightly these extreme conditions.
Yeah, it's must-do stuff.
Yeah.
This has been super duper amazing. Thank you so much for your time today. We really appreciate it. Looking forward to your session this week.
Thank you, Nicole.
Cheers. Thank you.
Bye-bye.
Joining me as my co-host for this segment is James Hawkins, who's a member of the HIMSS UK Advisory Council and Director of Strategy for NHS Digital. Welcome, James. Thank you for joining me.
Nicole.
And joining us, we have Tom Foley, MD, who's the Senior Clinical Lead for Data at the NHS Digital. Tom, welcome.
Hello, it's really nice to be here.
It's great to have you with us. So to start off, why don't you tell us a little bit about the session that you're hosting here at HIMSS this week?
Yeah, so we've just had a really interesting session on actionable data and ethical data. I think what was really interesting to me was that we had 3 or 4 presentations about different platforms that have been developed, some by national governments, some by the private sector, some collaborations between the two. But the theme that really came out through all of them was that it isn't a technical challenge that we're facing, that really the challenge in all of those platforms is the sort of socio-technical challenge and enabling people to use them and to apply the data to really help patients and clinicians to do their job better.
That's really interesting. I'm not sure I've heard the data question really framed as a people question. That's a really interesting angle.
So in terms of the presentations you heard, which countries are doing really well in this area and which countries are a bit further behind?
Well, I think we're here in Finland, so we couldn't not mention the work that's going on in Finland, and we had a great presentation from one of their national organizations, and I think the work that they've done on building up national registries over a long period of time is really innovative, and there's a lot to be learned from that. I think looking around the area here in the HIMSS Conference Centre, you see representatives from lots of different countries, and I can see just from where we're sitting now, there's a pavilion there from the US, and I think there's some really interesting work going on at the provider level within the US to make really good use of the data that comes out of electronic record systems. I think there's other really interesting work happening in Switzerland, for example, on developing a learning health system there at a national level. I think there's interesting work going on looking at the ethics of data sharing and so on in countries like Poland. I think in Asia there's a lot of interest in developing, again, learning health systems. And I think there's something to be learned from every country. I've obviously come from England, where I work at NHS Digital, and I think what one of the real strengths that we have is, again, national data sets covering the entire population, a large population of over 50 million, going back, in some cases over 30 years. And I think the challenge for all of us then is working out how we make those assets actionable.
Mm-hmm. And for countries that maybe don't have these large data sets, where do they start?
Well, I think it's very difficult, and I don't think you can look at one country and go, they're fantastic and we're going to use that as a blueprint, because every country is different. Every country, there's a different relationship between the population and the health providers, between health providers, between the health providers and the government. And I think there's a complicated, probably a complex context that needs to be understood. But I think one of the themes that came out in our session that I think is a good place to start for everyone is that of trust. And I think it's really important that there's trust as the sort of foundation for any data sharing setup that you're going to have.
I was going to pick up on that bit about trust. Obviously, there's a lot of different factors that impact trust. So we know about the UK. What about the other countries you've seen, and how have they built trust with their populations?
Yeah, I think one of the things that you often see in countries and indeed in regions that have been doing this work for a long time is that it often started small, maybe started at a local level and built trust between clinicians and patients, and then moved out to the kind of the IT professionals around that, and then brought in the kind of government organizations and built it up from there, and then showed the benefits. Really, I think is a great way to develop trust. So as well as being transparent about how you're using data, to be accountable for the results for that use of data and showing the benefits and bringing that back to the people who've contributed the data, both patients and clinicians, and then building it up from there. I don't think it's something that you can just take from scratch and just expect people to have that trust to begin with. I think that's
it's an interesting angle, trust. We don't normally think about that when we're talking about large amounts of data. I wonder, has the implementation of GDPR helped or hurt that trust that is trying to be established right now?
Well, I think there's that interface between trust and ethics and information governance. It's a really difficult area because there's no doubt that it's a complex area, and there's no doubt that it's very difficult to explain to healthcare professionals like myself, to IT professionals, to patients, what all that means, and there's a lot of confusion. And I know with the introduction of GDPR, you know, for a lot of people, the real sign that GDPR was coming was that they were getting lots of emails from lots of online service providers telling them that. I'm not sure how much we really got to understand what that meant for us and what that meant for our rights and our responsibilities with data. So there's been some really good work looking at that, actually explaining that to people, done by the Wellcome Trust in the UK and around the world, on kind of understanding patient data, how we use it, how we communicate about it, and I think we need to really learn from that sort of work to make more progress.
And what about, do you collaborate across Europe in terms of building that trust? Is there any lessons we can learn from not only people like the Wellcome Trust, but outside within Europe? Or?
Yeah, I think what comes through at an event like this is that there's a lot of diversity between different countries, and there are countries that are able to do some things with data that just wouldn't be allowed in other countries, and there are countries whose health systems are designed in such a way or set up in such a way or have evolved often in such a way that it enables them to do certain things with data or stops them from doing certain things. I think there's lessons to be learned from all of those, and I think it's when we take a step back and think we're not just talking here about data and how data operates within a particular country. We're talking about how an entire health system operates. And I think increasingly we can see that health systems run on data and can be managed on data and can be improved with data. And I think the legislation in place to manage entire health services has to take account of that, and in some cases does successfully.
Yeah, it's definitely a lot to tackle. We're almost out of time. Before you leave us, Tom, I'd love to hear what you're most excited to see or learn, or who you're most excited to visit here at HIMSS this week.
I think it's really exciting to see that lots of different countries are facing similar challenges, and to see those exemplars. And I think really what we're really trying to develop here is a healthcare system that can learn from every single patient who's treated and can improve from every single patient who's treated. And I think we see around here lots of ways that we can make that happen and that we can take home to our own countries. So I think that's really the most exciting thing for me.
Yeah, that is very exciting. So we're out of time, but Tom, thank you so much for joining us. We really appreciate your time and your insight. It's been great.
Thanks a lot. It's been a pleasure.
Thank you so much.
Yes.
Yeah, so there's no doubt this question of data is a transformational question when it comes to healthcare.
Yeah.
And you must face it every day at NHS Digital.
Yeah, we obviously collect data on behalf of the system in England. We link data and we disseminate it out both for really driving the life sciences agenda in the UK, but also trying to get actionable insights into better outcomes for patients. So yeah, it's a big old topic.
Absolutely, absolutely. So joining us next is Ronald Petru, MD. He's the CMIO at Radboud University Medical Center in the Netherlands. Ronald, welcome.
Hi, thank you.
It's great to have you with us.
Great to be here.
So to kick off, why don't you tell us a little bit about your session at HIMSS this week?
Well, I will be moderating a session on cybersecurity, which is for a physician maybe a little off topic, but I think it's very important to emphasize that as we say that health IT is becoming more and more part of the primary process of patient care, of healthcare, so is cybersecurity more and more becoming an integrated part of patient safety. And since patient quality of care and patient safety are my primary drivers, it's a very logical thing to be involved in this as well. And if we create new technology to tackle old problems, we should be aware of the fact that we're also creating potential new problems that we have to take care of.
Right, right. And the biggest challenge of all, as you mentioned, getting physicians to sort of buy in and care about this stuff, right?
Exactly.
How do you go about that?
Well, it's very important to empower care providers in general, not only physicians, but everybody who takes care of the patient, and to make them see that actually this technology is not like a bookkeeping that you do next to your work, but more that it's part of your primary care of the patients.
Right.
So documentation, but also everything that goes with it in the modern times is part of the primary process of patient care, and so is cyber safety part of the complete patient safety profile.
So the WannaCry incident that was worldwide, but we suffered quite a bit in England through it.
I heard about it.
Helped
Yes, I heard about
to raise the profile both from executive but right through the organisation. Did it have the same impact in the Netherlands?
No, and specifically not in my organization, but actually I don't even know about other Dutch sites that had a similar problem. And I won't be saying that, that we were any better, but we were always very much aware of this risk. And but one of the problems, especially with the WannaCry, was also that it was, if I understood it well, it was timed like a time bomb. So it was already in your system, which is even more of a challenge.
But it helped really educate everybody across the system in England about the need to invest, the need to take care. How are you driving that same cultural change through the work that you're doing?
Well, it's a difficult one, but we try to do it by going through the hospitals, by having stands. That's for example, we used to have a week, or we have a week every year about safety and privacy, and we have like a stand in front of the restaurants that's all the care providers of the hospital have to pass, and they are confronted with those things like, okay, so what do you have to do if you lose your phone with, for example, the app, the EHR app on it? How do you deal with patient data? Do you take them with you, or well, whatever? But it's also about facilitating a safe way of working, because if you you can try to force secure measures on people, but if they don't work for them, they will find ways to work around it that may be even less safe than what you actually try to achieve.
Right, yeah, I think it goes down towards changing behaviors, right?
Absolutely.
Not taking records home with you, being more careful with your phone.
Exactly.
So it's really much more of a sort of softer conversation than it is, you know, here's the new technology standards. I mean, how do you go about implementing those much more sort of softer things?
Yes. So, as with all technology, this is not a technology thing. This is, as you say, this is a change, a behavior thing. And so you have to offer attractive solutions for people that they really want to work with, because it makes life easier. It's more natural to use that instead of using your own WhatsApp, for example.
Right.
Things like that. So it's better to try to convince people by seducing them to use something that is actually safer and better, because it fits better in their workflow. But it's a difficult task. And on the other hand, of course, making people aware of the risks and aware of the consequences that happen. But it's a difficult discussion. Also because all technologies, even if they are not very safe, they are widely accepted as more or less safe. So sending messages through a fax or through a paper mail in an envelope, well, if you would introduce that technology nowadays, it would probably not pass. But since it has been established over the years, it's considered, well, accepted and more or less safe. So that sometimes explains why modern technologies that are actually better are difficult to implement.
So in addition to the cultural change required in the clinical workforce, is there the right level of investment in terms of the infrastructure, the hardware, the firewalls to make the hospitals safe? And has that case been made?
Well, certainly I think in my organization it is. But it is always the issue. I mean, we're dealing with the people's money. The money, the community, the society pays for healthcare. And it has to be a proportional investment. And it will never be 100% safe. Nothing will ever be. So you always have to consider if the last million you're going to spend on that last few tenths of a percent of extra security is really worth it, because it's money the people pay for healthcare. And of course they want the healthcare to be safe, but there is a limit to what you can spend unlimited amounts of money to make privacy and security even better, but then you will have nothing left to actually provide the healthcare that people pay for.
Right, that's a huge, tricky balance to find, right? The money that you need to take care of patients versus the money you need to make it secure. You know, do you see organizations, hospitals getting that balance right, or does that remain a big challenge for everyone?
It's always a challenge, and I'm pretty much convinced that we're doing a good job, but of course we are not 100% safe. We're making progress, even though I think we are already on a high level. We're still making progress and still trying to make it better, but yes, we always have these discussions. So if we spend all these millions on security, what does it mean for the rest of our healthcare process? How do we innovate our healthcare process? How do we make things better if we have no money left? So we will have to balance that, and we have to do the visible things, because that's what I always tell to my care providers. They say, well, why does the IT departments, information management as we call it, spend so many money on those things? I say, well, it's like with the fire extinguishers and other things that you need to have in your hospital in case of emergency, and you hope you never need them. But the same is with cybersecurity. You spend a lot of money and a lot of hours and investments on cybersecurity, on actually something you normally will never see, and hopefully you will never have to use.
If it works right, you'll never even know it was there.
If it works right, you will never notice, but you will only notice there's a lot of money and effort going in that direction without seeing a direct result.
It sounds like a really wide, sweeping challenge, though, and it's one obviously we face in our everyday lives as well. Is there an intersection of how we look at our own data security, our own data privacy, and how we start to look at that within our care provision, how we start to look at it when we go to the hospital, or is a greater awareness of data privacy helping this transformation within healthcare?
Well, I'm thinking if I understand the question right, but so you mean in our daily life? Well, usually, in my experience, many people are not very much aware or considering their privacy or security. Privacy and security are two different things. But obviously, if you have a security problem, it usually also leads to a privacy problem at least. And the more advanced technology gets, it also leads to real safety hazards, because if you confuse care providers, for example, they will act based on the wrong information, do wrong things to the patients, operations or medication or whatever. And if you go even further and you go to the Internet of Things, or even, it's a modern term that is now very popular, but I say, well, lots of our bedside devices have been integrated for years. So you may or may not call it the Internet of Things, but especially if it gets bidirectional, it means that you can actually, over the Internet, steer the ventilators, the infusion pumps, and so on, and the operating robots. So you will actually have access and really can do damage to the patients. And so I don't think everybody is aware of that, and people are quite well at ease, especially in my country, by putting everything on the Internet and don't make a lot of problems about their security and privacy, but it's relative. But as you get into healthcare, the risks are so high, the stakes are quite different.
Absolutely, absolutely. So unfortunately, we're out of time. Ronald, this was so interesting, a fantastic topic. Thank you so much for joining us. We appreciate it.
Thank you, Ronald.
Thank you.
Yeah, I think one of many sessions I think we'll see today and this week on cybersecurity. Is this a new topic, or is it just everyone starting to really pay attention, do you think?
I think everyone's starting to pay attention. I mentioned it on the interview there that the WannaCry incident in England did raise the visibility of the risk and has led to quite a change in investment in terms of right across the NHS in England in terms of protection and that clinical risk management.
Yeah, it's too bad we had to go through an incident to get that level of visibility. So joining us now is Cohen Kaz, who's the founder of Health Scouts. Cohen, welcome.
Oh, nice to meet you.
We're so glad to have you with us. To kick off, why don't you tell us a little bit about your session here at HIMSS this week?
Yeah, so I had the honor to open the keynote today, and I've been talking about how can I remove frictions out of the life of a patient, because that is one of the biggest concerns. If we look to the definition of a patient, it's someone where the healthcare provider has little knowledge about. And that sounds pretty counterintuitive, but I'm going to try to illustrate you. If I send a package with FedEx or UPS from here in Helsinki to Berlin, I can trace that package every 5 seconds, which I find absolutely normal. My average cancer patient, my Alzheimer's patient, is 8,700 hours a year by himself, not linked to a healthcare provider. So how can we provide care? We cannot. And that is exactly what I think we're going to do. There is reason to believe that we can switch to, or from what we currently have, sick care, we wait till people get sick, to real healthcare, because we will be able to anticipate in time when something happens, when something goes off track, so that we can correct and bring people back into kind of the healthy behavior. And so the big dream is to build a world in which we die young, but as late as possible. That is what I'm going to try to do. Now that comes from the following. I'm trained as a molecular oncologist, so I spent years seeing cancer patients, always end of life. And the last thing I've been doing in my kind of conventional career is making drugs to treat brain cancer in children. More confronting than a brain cancer child, you will never see it. And my eye-opening moment was the first time I went to mainland China, something like 12 years ago, where I learned a very old system, 2,200 years old, in which the doctor got paid as long as people in the village remained healthy. How cool was that?
Wow.
So I started to study on why we did lose that, and we lost that big time, and how we could build that again. And 5 years ago, I wrote a book on that, Sick No More, which was kind of the roadmap to get there, essentially explaining that because I know nothing of my patients, I cannot be that Chinese doctor who was so close by that he could interfere immediately. And that is where digital technology will start to help. Digital technology will allow us to start entering the real world of our patients in completely new ways. Not intrusive, but in ways that we can measure things people even didn't realize you could measure, so that we can offer them new experiences, really cool experiences, which I call delight, so that all of a sudden we can start to make healthcare delightful.
Right.
And that is the topic of what I explained this morning.
Right.
That healthcare becomes delightful if we get the biggest friction out of the way. And the biggest friction is getting sick in the first place.
Right. Well, it must appeal greatly to patients, to people, right?
Absolutely.
Because it puts the ownership of your own health. You're in the driver's seat. How does it play out with doctors and healthcare professionals? It's a total flip of their script.
Yeah, it's a complete flip.
Yeah.
And sometimes I don't want to have ownership of myself as a patient. We can even do it better. Let me explain. Once I get 85 years old, I start to forget to drink. I dehydrate. And then you can have someone saying, well, you have to drink. But we built a patch together with a Japanese company which sticks 1 month to my 85-year-old skin and which measures dehydration. Good? No, not good enough. Because if I forget to drink, well, how can I interpret the patch?
Right.
So we link the patch via the Internet of Things with my TV. Being 85 years old, I watch quite a bit of TV. And now every 3 hours, my TV says, Koen, go drink. And all of a sudden, I've changed behavior in an invisible fashion using technology. And that's the real dream. That you don't have to wait till you get a patient and sick, but yet you can interfere faster. We're not there yet. Let that be clear. We still have patients. And now we start to see that very often people think, well, if you enter into the real world of a patient, there will be a privacy issue. That's a non-issue, really. Privacy, I think, is completely overrated. And I'm going to try to explain. We have the honor to work with a number of pharma companies to help them think beyond the pill, beyond offering something to just treat the patient. And one of the big companies has launched a patient delight manifesto based on my book. How can we bring delight to patients? So we started to work with patients, and we started to find out, well, what is it that really annoys you, or whether you have anxieties about, besides the sickness. And one really fantastic example really stands out, where we started to work with epilepsy patients. So epilepsy patients sometimes get a shortcut in their brain, a seizure. They're out of this world for 10 minutes, they re-wake and they have to continue their life. If that happens, they might have a hard time to drive back home with their car. They don't dare to do that. They might have a hard time to get to the school of their children in time. They might have a hard time to meet their boss at 6. And some patients even told us, well, if it happens, I'm not able to cook dinner for my kids. So we came up with an app, a simple app, where one press of the button sends a signal to 2 friends in my network, can you please come and get me? My car is here. To my school, can you please keep my children in daycare? To my boss, can you bring the meeting of tonight till tomorrow? And to Domino Pizza in my city, can you deliver 2 pizzas at night? In order to do that, the patient opened up his most private data, the name of his children, where he lives, who his boss is. If you can manage to do that, you can do whatever.
So you talked about one application about monitoring water hydration. In terms of predictive prevention, I guess is what you're talking about taking preventive action. What other examples have you seen that's happening throughout Europe or the world?
Finally, we start to use the biggest present we ever got from our parents into predictive healthcare. That's our genome. So we start to sequence people and start to look to predisposition. If I look to myself, I will turn blind. I'm predisposed to get blind. I don't know when. But I found that a fascinating insight, because since I know, I take one supplement, which I complement my diet with, to delay the degradation of the back of my eye. And then the first pieces of software came out. AI software, where I no longer need a doctor to diagnose my eye. So combining genomics and a software digital tool starts to allow me to predict when the eye is really worsening and to interfere in time. So we start to see that in eye care, but we start to see it a big time in cardiovascular disease. What happened till a few months ago, a cardiologist sends you home with an appointment, the 1st of July. I don't want that. A few months ago, I wanted a cardiologist who sends me home with a casket around my smartphone from a LifeCore, which allows me to put my fingers on the smartphone for 10 seconds, records my heart function, stores it in the cloud, compares against baseline, and something is offline, he or she calls me and says, well, we're not going to wait till the 1st of July, I want to tweak something. Now we start to have wearables, which are no longer gadgets, but which start to become medical devices. So we start to feel that we can extend the power of the cardiologist if he starts to learn that these apps, these tools, help him to become a 24/7 companion of his patients. And this way, he starts to resemble the Chinese doctor, going back to living close to his villain.
Right.
So how far is this all, how many years away until we see this?
From all the things I presented this morning, everything is real. All the things which I presented are currently being developed or being put in practice. The biggest challenge is not technology. It's not the amount and the excitement you can create, but very often is the system ready to accept something new into it based on, can I trust something new? And I guess you have heard the word trust already quite a few times. But the fact that in order to see a fax machine in function, I still have to go to a hospital tells you something, that it takes a while before you get something trusted big time out and get it replaced by something else. And I think for that reason, our task as well, people trying to make a vision on how the future could look like, is to not just build the trust of the current people in healthcare, but find completely new ways to let them shine. And what I find a fascinating way to learn people shine is that if they can give me something for my birthday wish list, which I expected to get, I'm happy. But if you can give me something which I even didn't expect that existed, I'm super happy. And that is delight.
Right.
And so that is the entire fil rouge, that you can change healthcare if you learn healthcare providers new things they didn't know before, and they can use to shine towards the patient.
Excellent.
Right. And where's the best place to start? Do you start with patients, with people expecting this from their healthcare providers, or the other way around?
Yeah, I think it's a good question. It goes in two ways. Very often, as a patient, I'm not looking forward to go to a hospital. I'm 65 years old. What is the biggest challenge to go to the hospital? That is, who will take care for my dog? What we installed at the University Hospital in Bristol is a kennel. So I can take my dog to the hospital. That reduces the stress of going there. It's the hospital which does do something for me, making me looking forward to go there. I have to be at an infuse, 3 hours. Not nice. But what we do, if I'm a child, we put a Batman or a Superman casket around the infuse, and I sell superpower to the child. And if we have an elderly patient, 75, the time he's on the infuse, we learn him to do WhatsApp or Snapchat. And he comes back home, and he has a new way to communicate with his grandchildren. Learned in the hospital. How cool is that? So it goes two ways.
Yeah. Oh, that's so cool. Really interesting stuff.
Okay.
I'm gutted that we are out of time, but Colin, thank you so much for sharing your insights with us. That's great.
Thank you.
All right, so up next, we have something really special for you. We're going to do a little bit of a showroom tour to see and experience virtual healthcare. This is our Kotona at-home tour.
Hello, I'm Stephen Wellman here with HIMSS TV. We're on location in Helsinki at the HIMSS Europe and Health 2.0 conference. Right now, we're about to take a tour of Kotona, a facility showcasing new digital healthcare delivery systems. I'm here with Jorafina, who is the development manager here at At Home. Thank you so much for joining us today.
Thank you.
Could you tell our viewers a little bit about what the facility is and what we're about to see in the tour?
Well, we originally put this up at the Helsinki Design Week last year, and it was always kind of a concept that is going to evolve and develop. One of the solutions I'm really proud of is the GPS tracker, because we were able to provide both safety and freedom to our customers. One of the really success stories has been the remote care. So it is really a very simple tablet device that the customer has at home, and the other end is our nurses here at the office, and we can have all kinds of contacts. There's a medicine intake. Yeah, it's really versatile service. Yeah.
Great. Well, thank you so much for your time today. We look forward to the tour a little bit later.
Thank you.
And we'll be showing you some of the tour as we go into the demonstrations in a bit. Please stick around for that. This is Stephen Wellman with HIMSS TV.
My name is Erik Gerritsen. I'm the Secretary General of the Dutch Ministry of Health, Welfare and Sports.
Thank you for joining us today on HIMSS TV.
You're welcome. You're welcome.
Could you tell us a little bit about the tour we just saw here at the facility in Helsinki, the remote care delivery technologies that are on show here?
Yeah, I think it was a great presentation. Compliments to the people from Helsinki. They're using all kinds of digital technologies helping people to live at home longer. And as I think everywhere in the world, but the guy who explained it emphasized that in Finland, living at home is holy business. So people want to live at home as long as they can, and a lot of technologies that were shown here is actually helping them. So I'm really impressed that they're not only talking about it, but also walking that talk and actually doing it. There was one question I raised that was a bit surprising. The answer was a bit surprising, that because you would expect that, especially Finland has a lot of rural areas as well, but there's a lot of distances that you might expect that they would have implemented it there as a priority. But they started at the capital, and I think a large percentage of Finnish people live in the capital, so that's also a smart start, I think. But they're thinking about rolling it out to the rural areas, but not as a national project yet. So that was a bit surprising, because I'm all about interoperability and standardization. So they have it, as we all have, they still have a challenge there. But the project here was amazing, and they compliments for the fact that they're not only talk about it, but actually walk their talk.
Great, thank you for your impression of the tour.
You're welcome.
We're finishing up our tour here of Kotona, otherwise known as At Home, a remote delivery care treatment center that is a model for the future of digital health here in Finland. Behind me, you'll see a series of nurses who are remote monitors for patients throughout the Helsinki area. They're collaborating with patients on any number of things, from checking to ensure the drugs are being adhered to making sure that the patients have eaten within the last period of time, coordinating transportation and delivery of other services to these homebound patients. Thank you for your time. We'll be here continuing at HIMSS Europe on location in Helsinki. Stephen Wellman here. Thank you for watching.
So joining us now is Markus Mucinich, MD, who's the co-founder and managing director of Flying Health. Markus, welcome.
Nice to meet you.
Great to have you with us. To start off, why don't you tell us a little bit about your session here at HIMSS this week?
Yes, it's a very interesting session, because it's, let's say, the session is about the roots of flying health. Why not the roots of flying health and the roots of digital health? The question is, why is digital health so funny, and why does it enhance the quality of medicine? It's because digital health meets you where you are in your everyday life. So it's not at the doctor where you're just 1 hour a day, 1 hour a week, or 1 hour a month if you're lucky, or never if you're very lucky. But digital health meets you at your everyday life, and the session, or my part of the session, is concerning the everyday life in the car. So, as you probably know or not know, the average European lives 3 years in his whole life only in his car, by steering his car.
Wow.
That means 3 years doing nothing else, looking on the street and steering at the steering wheel. But if we have the autonomous car, so you're still in the car, but you have plenty of time. And let's say, what are you doing with the plenty of time? The autonomous car. And then, of course, if you're keen on digital health, you do health in the self-driving car. That's the session about.
Right.
So what innovations are happening in terms of car design? I've heard of some things like Jaguar in the UK, and what's happening?
That's a very interesting question, because if we think about autonomous driving cars, we always think that's a car like today, but you don't have to use the steering wheel.
Yep.
But that's not that. If you think about self-driving cars, and if you see the concept cars, you see, let's say, spaces where you are in, and the spaces are driving. It's not a car like you know the car today. So it's much bigger, and there's nothing you usually have in the car beside the steering wheel. So it's a private room. And this private room makes it perfect for everything, and it makes it perfect for let's say, the intimate situation you have if you want to talk to a doctor or you want to prepare for your health.
Tell me a bit more about that. So what sort of things is Flying Health?
So Flying Health was founded just as an investment company, and we invested a lot of years ago into a company which went bankrupt, which provided digital therapy, and we negotiated in 2013-14 a very big contract with the German healthcare insurance company, and we had the first contract on reimbursement of digital therapy. That was that's our roots of Flying Health. But then we became a bit famous, because we made it possible to earn money with digital health. But what then happened was that, for example, the car manufacturer Audi came to us and said, okay, we are on the way to produce self-driving cars, so there will be a lot of time. We have our clients, our former driver in the car. What are we doing with them? Do we provide videos? Do we provide whatever? And what about providing fitness and health? And Audi had a program which was called Audi Fit Driver, which was about fitness. And we said, okay, what would be if we could tell the driver that he will step out of the car healthier than he stepped into the car? What do we have to do? And so we developed a program and a concept concerning what kind of healthcare services could be provided in the self-driving car.
Right.
And that's very interesting. It's a very broad field.
Yeah, well, it's a really interesting idea because when you take away the driving element, you really make the driver even more sedentary, right? Already we spend 3 years, as you say, sitting in our cars, just driving around. If they drive themselves, now we're just sitting.
Yes.
So the question of how to make that a more healthy activity is a really interesting one.
Yes, let's say it's what we call the 25th hour of the day. So you're inside the car, you can't step out, and you have plenty of time.
Yeah.
So most of the people, what are they doing? They will do business, they will watch videos, they will do their telephone calls, but why not online consultation with your doctor?
Yeah.
Why not psychotherapy? Why not, let's say, thinking how to manage your diabetes? Why not, let's say, thinking about any complex things concerning your health issues? So it's let's say it's like the doctor's room, or like the doctor would visit you at home, but in the car. But the intimacy it's the same, or can be the same.
So have you prototyped any of this? Is any of it on the
yes,
market?
we did a prototype with Audi. And we were very lucky that we worked with Audi. And now let's say, we'll see what Audi will do out of the prototype. But we are going on. We work, let's say, we are now diving very deep into the project because we found it's let's say, it's a thing of the future, an issue of the future. Yeah. Because Audi or VW, they will have their first driving cars, fully autonomous driving cars in 5 years. So let's say it's enough time to build a business model on this, and let's say to provide real very good services, to negotiate with a healthcare insurance company who should pay for this. So now, let's say, the time has come to make out of this concept a real business plan for automotive health.
And in terms of the user research, are people out there interested in getting healthier as they drive to work?
Yes, it's very interesting. One of the startups we worked together with this concept was My Sugar. And My Sugar is, probably a diabetes management platform. And one of the founders, he showed us a picture out of his car, and he put his smartphone in front of the screen and there his blood glucose was measured. He could have a look at his blood glucose from his continuous blood glucose meter on his arm. And so he said, when I drive with my car, I have to put my smartphone in front of me, which is ancient, which is Stone Age.
Yeah.
And he said, okay, I'm happy that there is a company like Audi who will help me as a diabetes patient and as the founder of My Sugar, let's say, to provide this service integrated into the IT systems of the car. So it's not only that the patient will love it, also the founder of the healthcare startups will love it.
So it seems like this mythical 25th hour of the day that driverless cars could bring us would be of great interest to a number of different applications. How do you make sure that one's personal health is sort of top priority, right? As we move towards driverless cars and we get this hour or 2 hours of our commute back in our life, how do we make sure that healthcare is top of the agenda for how to spend that extra time?
I think we can make this happen if we have, let's say, good products for this. I think the patient will like it. The manufacturers, they are looking for everything they could provide into the car, and we need, let's say, sufficient business models. I mean, healthcare insurance companies who pay for this, because what we think is if you provide digital health to the patient, that's something healthcare insurance companies have to pay. Okay, you can do it out of the pocket, but if it's, let's say, serious health, and we call this serious health, it's not funny health, it's not just counting steps, it's not just counting calories, it's a part of the let's say, the digital health pathway in diseases which are very serious. So if we provide a serious tool, then we can put it into the car, and then the healthcare insurance companies will pay for this. And that we made sure in this concept, so the German healthcare insurance would have paid for it or it will pay for it if it comes live.
So in terms of other activity across Europe, obviously Germany has a great heritage in building great cars, and BMW and Volkswagen and Audi. Do you see Germany taking a lead across Europe on this?
That's what we hope, and I think, let's say, the signals show this, because in Germany we have the manufacturers of cars, and they all look to Tesla, but Tesla, perfect electric, perfect everything, but no health.
Yep.
So I don't know their health. And we have a healthcare insurance system which would pay for this. And I think the healthcare system in Germany is very interested in providing services for a patient with chronic diseases. So we have, let's say, 2, 3, 4 signs which make me very optimistic that Germany could be in front of this.
After Germany, where do you see it going next?
I think it's a worldwide thing. Let's say we talk to My Sugar, and My Sugar is meanwhile worldwide with nearly 2 million users, many of them in the States. So I think if the technology is, let's say, ready enough to be brought into the car, then let's say wherever the car is sold, there will be, let's say, and always, and in the whole world they have the same health issues. So I think there's no border, but maybe it's first in Germany and then spreading to the world.
Yeah, I mean, I guess in an insurance market, it's probably easier to create the commercial model for it. In a traditional taxed healthcare system, it's probably harder.
Yes, I think what we see in Germany we have a healthcare insurance system where you do not have to pay anything, expect monthly your fee. And so the Germans are not used, and they don't like to pay out of pocket for things. They pay a lot of out of pocket, but if the German patient says, this is serious health for my serious disease, they don't pay. If they say, okay, it's just something nobody pays, so I like it, then they pay for this, but they would never pay for, let's say, diabetes care out of the pocket, because they say that's for the healthcare insurance companies to pay, or for depression care, or name it, or for pregnant women. It's perfect to have, let's say, the pregnant women driving in a car, being safe, being, let's say, monitored. So there are a lot of use cases concerning every status of health, and what I said, it's a real serious thing concerning healthcare.
Well, this was so interesting. I'm gutted to tell you we are out of time, but thank you so much for sharing with us. And Marcus, I think the future of flying cars is nearly here, driverless cars, nearly here with us. Thank you so much for joining us.
Thank you.
Thank you.
Okay.
So what do you think? Are you going to a driverless car soon?
Certainly one for the future, yeah.
You know, I envision a world where not only do we have driverless cars, but our train services are the same sort of deal, where you can get into a nice little compartment, get done some stuff for your day, and then and then get to where you're going.
Yeah. It's going to be difficult, because obviously the car market will change when it becomes driverless. There'll be more sharing probably, so it'll be quite harder to keep that personal space to do some healthcare.
Yeah, well,
bit of an issue.
And like I asked, I think that additional mythical 25th hour is going to be really vied for, but we'll see. So joining us next is Charles Jaffa, MD, PhD, and the CEO of Health Level 7. Charles, thank you so much.
It's a pleasure to be here.
It's great to have you with us. To kick off, why don't you give us a sense for what you're talking about here at HIMSS this week?
I think the advent of the global and independent implementation of FHIR has been a remarkable accelerated course, and I think there's hardly a corner of the globe that doesn't want to understand how to leverage this remarkable platform.
Yeah. So in terms of FHIR, there's obviously been a big acceleration in the USA in terms of adoption of FHIR, and some action in the UK. What else is happening in Europe in terms of FHIR?
Different regulatory agencies around the globe have begun to mandate FHIR adoption and integration within their own health systems. Certainly, a sea change occurred in the United States when Health and Human Services, as well as Medicare and Medicaid, both released proposed rules saying that the open API that they've been talking about for 4 years will be FHIR. We have had at HL7 enormous interest in building the community of FHIR that has grown exponentially, both in Europe and in other continents. And so we're excited about it, and we're trying to scale to a remarkable demand.
I imagine you have to build some scale really quickly. How have you seen this space change over the last couple of years, and where do you think we're headed? FHIR is now 9 years old. When HL7 introduced the concept, there was skepticism, dare I say, cynicism, about whether it would be utilitarian or simply yet another academic exercise. It's proven to be not only remarkable in its ability to scale, but also in the broad growth of communities of interest, whether it's genomics or social determinants, whether it's patient access or population health. The clinician community, for example, has finally embraced HL7 FHIR in a means that we haven't seen when it comes to healthcare IT. And this is true not only in North America, but also in Europe.
So I'm aware that the Apple were part of the consortium in the States in providing access via iPhones, etc. However, Apple are constraining that to the States to get it right. Are they ready to go into other countries yet? Because that would be a big game changer.
I wish Apple would tell me. Right. In January of 2018, Apple announced that they had integrated FHIR within the operating system.
Yep.
It started out as a small pilot program of 12 academic health systems, and has grown today to perhaps more than 600.
Yep.
The ability to manage that growth is remarkable on all fronts. The challenge will be to understand whether the partnership between HL7 FHIR and Apple can support the rapidly evolving pace with which FHIR changes. HL7 has been committed to developing its standards in an open community process, and traditionally it has been slow. The FHIR community has exceeded all norms for the pace of development, and so we saw the publication of Release 4, which was the first normative standard of HL7 FHIR, and now we're beginning to see the promise of Release 5, and it's going at a pace parallel to the IT industry of every 18 months, a major revision.
Wow, wow, that's moving super fast and moving us straight into the future. Time is also moving fast for us, and I'm so sorry to tell you that we are out of time. But Charles, I really appreciate it.
It's been my pleasure.
Thank you so much for being with us.
You.
We appreciate it.